All right. Hello, everyone.
This meeting is being recorded.
Hello, my name is Dr. Talha. I am a trust-grade doctor in Nottingham University Hospital. For those who have joined earlier, you know that this is a surgical lecture series based on for the people who want to go for the MRCS in September. For those of us who have joined us today, today we have a lecture by Mr. Bakht Yawar. He is my senior. I have known him for quite a while. He's currently a CT2 in General Surgery in Northern Ireland, and he has been really kind to join us today and give us this lecture because uh, his main interest is trauma and orthopedics, and he was really interested in giving this lecture, and we really like to thank him for that. So, without any further ado, I will over to you, Mr. Bakhtiar. Thank you.
All right, everyone. I think Tala has given an introduction for me. I would just add that um, I do trauma is one of the things that I'm most interested in. So I really feel very passionate about giving this lecture today. I hope all of you are looking forward to this series as well. And without further ado, we'll just begin this lecture for today. This is mostly going to be focused on trauma management, and it will be useful for people who are taking their MRCS Part B as well, because I am going to involve some of you people during this lecture to as I'll try to make it as interactive as I can. So trauma management and assessment. So with trauma management, the first thing that comes to our mind as surgeons is ATLS, which is the Advanced Trauma Life Support Protocol. And the things we're going to go through today are basically an introduction to major trauma and a history of ATLS, how it was first formed and how it began initially, and the principles of this scheme of managing patients that we have as well. And we'll also focus on some special interest groups with specific injuries about such as head injuries or C-spine injuries, which are really hot topics during MRCS preparation as well. So the first thing is major trauma. So what is basically major trauma? Major trauma can be defined, or it is defined as a combination of injuries which can be life-threatening, or it can be life-changing because these injuries can lead to long-term effects on people. And these can be either blunt injuries or penetrating injuries. Management is basically the same. We have to manage these patients according to our ATLS protocols. And injury severity score in these patients, according to, so we have this injury severity score, which is mostly research based. So it's not usually used in clinical practice that we can see. But an ISS score of more than 15 is defined as basically major trauma, but that's purely academic. And it is the most common cause of death in young people. Almost 15,000 people die every year in the UK because they're involved in accidents and have trauma. And it also is a huge burden on the economy. And the UK loses about £3.5 billion every year because of people involved in trauma. And the thing is that the prognosis of a trauma patient it's very dependent on effective management and initial identification of their injuries. So if they're left too long, they'll just keep on getting worse, and these injuries will show up, or they will become apparent at one time or another during their hospital stay, mostly. But the prognosis of these patients depends on how quickly we identify these and manage them, and that's why ATLS is such a good guideline as well. So how ATLS basically started was this gentleman, his name is Dr. Steiner. He was involved in an accident where he was traveling with his family, and their aircraft fell and they had an air crash. And this was back in 1978. So he actually noticed that the level of treatment that they received at their local center was not really up to the mark. And he felt that he could have taken better care of himself and his family in the field compared to that. So at that time, it was mostly they were managing patients according to taking a full history and physical examination instead of focusing on what's going to kill them first. So this has since then been adopted by the Royal College of Surgeons, in the UK as well, and both the Royal College of London as well as Edinburgh, they provide this course as well at multiple centers throughout the UK. And this has become a standard of care for trauma patients in more than 60 countries at the moment, and the UK is one of them. So it's very important that we know about at least the basics of ATLS while we're going into our MRCS exams, because they do expect you and they will ask you about, they will have a station on ATLS if you're going for your Part D. Um, I have very rarely heard about anybody who has not had a trauma station in their MRCSB. All of us would have a station on this. Now we're going to, I'm sorry.
I think it was one
Uh,
of the participants. I have muted him.
okay, no problem. So so there are some basic themes for the ATLS. So the first thing is that it is a very systematic kind of approach. So we've all done our ALS as well, or most of us will have done our ALS by this time as well. So the ALS was actually based on the ATLS, and ATLS itself was the first protocol which came out, and then then the medical community, they also followed suit with the surgeons, and they came up with ALS as well. And it basically is focusing on evaluation and management of a patient at the same time, and identifying the thing which is going to kill them first. So an airway problem is going to kill somebody quicker than a breathing problem, and breathing problems are going to kill somebody quicker than a circulation problem, and so on. But this is basically the basic theme of ATLS, that we have to prioritize things based on what's going to kill the patient first and manage accordingly. But we also have to do our evaluation at the same time. So we have primary surveys, secondary surveys, which are more detailed assessments, and then we move on to things like what we call tertiary surveys or definitive treatment, but that is out of the scope for this lecture that we're going to go through today. And another thing about ATLS is that it defines roles of all the people who are going to be involved in the care of a patient. And it relies very heavily on good and effective communication. So, unless all the people know that what they're doing, and unless there is a team leader who's effective and can take care of all the things from a distance, basically, um, things start falling apart. And that happens quite often in our emergency departments as well, where there's no leadership, and nobody seems to know what they're actually doing. But ATLS basically, it 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 tries to put people into roles, and it basically tries to bring forward leaders, or clinical leaders in management of trauma patients. So now we're going to the first thing is that we're going to move on to the primary surveys. So the first thing in primary survey is C-spine control. So the thing is, all patients who are going to have high energy or high risk mechanism of injuries, they're going to have there's a very high likelihood that they can have C-spine injuries, and that's true for anybody who has a fall or is involved in a road traffic accident, whether they were driving a vehicle or whether they were hit by a vehicle. It's basic management that we need to secure the C-spine first. And the position that is ideal is in neutral position. We should not be rotating, hyperextending, or hyperflexing the neck at any time. And 3-point mobilization. So has anybody? So we've all heard about 3-point mobilization. So what we basically focus on is a collar, blocks, and tape. So all three things are going to ensure that we will be immobilizing the spine correctly. And we can assess as well for the C spine by checking for any tenderness in the midline over the spinous processes, or and asking to check the range of movement. But we only should do that after after we have done some sort of imaging, especially in very high energy mechanisms of injury. ATLS is quite lenient about getting CT scans for these patients. And another thing about elderly patients is that if they tend to get a head injury, they usually have osteoarthritis or spondylosis of their C spines, and they are at very, very high risk of having C spine injuries. So getting an imaging in these patients, if, for example, if they're going for a CT head, it's useful to get a C spine in these patients as well, because with all the osteoarthritis, it might be extremely difficult to assess their C spine just based on X-rays. Um, and if you're unsure, then go for imaging. ATLS guidelines these days recommend imaging if there is any sort of confusion whether the C spine is intact or not. So this is basically, these are some diagrams which show how we should be immobilizing these patients. These basically say the same thing, that uh, flexion or the neck should be kept in neutral position and should not really be rotated, flexed or extended. Next thing is airway. So can anyone tell me over here how we're going to assess somebody's airway? Any volunteers? Guys.
I think you
Okay.
should randomly pick a person from the screen and ask them that they should answer the question. If they can't, then we can move on to the next person.
Okay. Just ask somebody. So Hamza Sarfaraz, can you tell me how we're going to assess the airway? All right. So the three basic things to assess anything are basically to look, listen, and feel. So looking at the airway, basically you're looking at whether these patients are making any, um, if there's any chest movements or not, any breathing movements. Listening is basically for any gurgling noises or snoring or even normal breath sounds. And feeling is basically if you can feel that there is any breathing, that if they're able to breathe. And basically the way you do it is you go near their face and try to assess from uh, a level at which the patient has been placed. And any foreign bodies, they should be removed. Suction should be provided if there is any secretions after opening their airway. And all patients should be started on 15 liters of oxygen by non-rebreathable mask before anything else is done, and this can always be weaned down later on. And the interventions that we can do for these patients, so there's transient, definitive, and surgical interventions that we can do. So nasopharyngeal, oropharyngeal, or eye gels, these are the kind of airways that we can provide to patients, and all of us should be able to provide this basic management. Endotracheal intubation is usually provided by the anesthetic teams in most hospitals. And if they're not able to do that, then a surgical cricothyroidotomy or a tracheostomy might be indicated. Now, can Nuhil, are you there? Nuhil Iqbal?
Yes.
Mute. Yeah.
So Nuhil, can you tell me why it is important to give a definitive or go for a definitive airway if somebody is able to tolerate like an oropharyngeal or a nasopharyngeal airway?
Because to avoid the risk of tongue falling back.
Okay, that's correct and that's good. But do you think if so somebody has come in with trauma and they have extensive facial bruising and injuries, and you're worried about their airway, and you have put an oropharyngeal airway in, so we always tend to say that if they're tolerating this, then we need to give them definitive. So that is absolutely correct, that if you do not change it to an if you do not give them a definitive airway, then they're actually tolerating this, which does not really bode very well. So their GCS
Yeah.
must be quite low as well with these things.
Yeah.
A normal person is going to have a gag and cough reflex, and they should
Yeah.
not be tolerating it. So if they're tolerating this, then that basically means that the moment you take it out, their tongue is going to actually fall back and they won't be maintaining their airway. But very good. We'll move on to the next slide. So these are basically the airway adjuncts. I'm sure all of us have seen these, but if anyone has not seen any one of these yet, so this is an oral airway or an oropharyngeal tube. Um, we should be directing this area, this end, the inner end towards the ceiling, and then we just turn it downwards as we put it in. This is a nasal airway, a nasopharyngeal airway, and we just have to be careful about the direction of the uh, inner end of it while we're putting it in, just so it does not sit right next to the wall of the nose. It's just that we need to see which side it is. And eye gels are over here, which should be very well lubricated when they're being put in. They're very good. Normally, many of the anesthetists use it even in theaters. And this is an endotracheal tube. We so endotracheal tubes, or these are usually inserted by the anesthetic teams over here, but we should know that we need endotracheal tubes usually sit below the level of the vocal cords, and that's why they are called definitive airways, because they will not move from over there, and they any of the upper airway tracts, any problem with that is not going to lead to an airway compromise if you have an endotracheal tube in. And next we are moving. Yes, so these are surgical airways, or in case we are not able to get an endotracheal airway. So Kinza, can you give me any examples why when we might not be able to provide um, an endotracheal tube or a definitive ETT? So what might be contraindications to that? Kinza?
I think they are muted, so
Okay.
they would not know that. Before we move forward, can you please make sure that your screen is on slideshow?
Okay.
Thank you very much.
Very good.
Most of
So
the problem is the most of the people who are attending are mute, so we have not allowed them to speak up sometimes, so that
okay.
might be the reason.
Okay, no problem. So these are a few ways to provide surgical airways. The first thing is this over here. The first one is a cricothyroidotomy. So it's basically in the cricothyroid membrane, which is just below the level of the Adam's apple and between the cricoid and thyroid cartilage. So there's a very small area at that in that area, and this is to provide emergency airway support to people. And we just insert a needle, and this is not really a definitive thing. The more definitive things are to provide a proper um, cricothyroidotomy with a tube in, or sometimes tracheostomies, which might need to be done as well. But these are these are usually provided in case an endotracheal tube is not indicated, or if there's any contraindication to that, or if it is not possible to insert one. Next, we move on to breathing. So basically, the first thing we're going to do is, for breathing, we have to assess several things, which is going to be the position of the trachea, the jugular venous distension, respiratory rate, and saturations. And the way to assess breathing is basically it's the four things: inspection, palpation, percussion, and auscultation. Things we have been doing for a very long time in examination of the chest. And I normally tend to auscultate for the heart sounds as well at this time, instead of coming back to that during circulation. Um, so in terms of inspection, we have to check for any deformities, check for chest expansion, and any bruising or any flail segments which might be visible. It's very important to remove all the clothes and anything that's on the patient while we're assessing them, just so a proper assessment can be done during inspection. Palpation, uh, and percussion for checking for resonance. And at this stage, it's it's usually useful to get a blood gas as well as a chest X-ray, order for chest X-rays at this stage as well. And the interventions which can be done to improve somebody's breathing may include needle decompression in case of pneumothorax, or a chest tube might be is usually needed if needle decompression is required as well for a pneumothorax. So um, I was going to ask some people, are there any volunteers for, or is Hamza here at the moment or not yet? I can ask about these things. No. Okay, so the first image over here, it is basically showing a lung contusion. Um, the second here, we can see a pneumothorax. And the third one over here is showing a hemothorax on the left side. So what's basically required is in needle thoracostomy, it should normally, classically we used to say that it should be done in the second intercostal space in the mid-clavicular line. But now new recommendations by the ATLS say the same thing as, or the site of insertion should be the same as doing a chest drain, which is in the triangle of safety. And it should be done just above the rib to prevent any injuries to the neurovascular bundles. Chest drain is to be done in the triangle of safety, and we have to be careful about the direction of the chest drain as well. So upwards direction is for a pneumothorax, as all the air will collect superiorly. And for a hemothorax, the dependent area is at the bottom end of the chest. That's why our chest drain should be directed downwards. And the triangle of safety, I'm sure many of us already know, but the triangle of safety is the area between the pectoralis major, its posterior end, or the lateral edge, the anterior edge of the latissimus dorsi, and just above the, or the superior border of the sixth rib in the fifth intercostal space. So next we move on to circulation. So we need to check for obvious and occult bleeding, and there are 8 sites. Is any volunteers to let me know what the 8 sites are? I'm not able to see the list of people with me at the moment. No. So the 8 sites that we have to be worried about include the chest, abdomen, pelvis, the 4 long bones of the upper limb, the 4 long bones of the lower limb, which is basically the humerus, the 2 humeri, the 2 femori, the 2 tibia, and as well as we need to know about any bleeding which is present at the bed. And we also have to look at any bleeding that might have happened at the site where they actually had the injury. So the information from paramedics is very important as well. And if we can arrest any bleeding with pressure or tourniquets, we should do that. But blind clamping is not really recommended these days for any vessels which can't really be seen. It's better to apply pressure or tourniquets or a pelvic binder in case of pelvic injuries. And we need to check for features of shock as well. And the important thing is to get 2 wide bore IV cannulas and take baseline bloods at this time as well, including group and cross match if we're thinking about any circulatory problems. ECG is also recommended, especially in cases of chest trauma. And bleeding patients, it's really important. It's one of the most important things of ATLS. Bleeding patients need blood. If we give them IV fluids, it's not going to make a difference. They will need blood. Sometimes you might hear about permissive hypotension and things like that, where the systolic blood pressure should be kept above 90. But the gist of it is, if somebody is bleeding profusely, then they will need blood. And the things that we can do in terms of investigations are fast scans or CT scans. Usually these days we're very good at getting CT pan scans in most of the trusts around England, and we should be able to get that unless somebody is extremely unstable and can't really go to the CT scanner. In that case, they should be going to the emergency theaters directly. And if it is difficult to get IV access, then intraosseous access should be sought in that case. And these are just the classification of hemorrhagic shock according to ATLS. So basically, there's 5 liters of blood that we have in our circulation. A very easy way to remember how all these classes of shock is basically the scores in tennis, which is 15, 30, 40, and then more than 40, or it's actually the end of the game. But up to 15% blood loss or up to 750 mils blood loss is class 1 shock, and class 2 is 15 to 30% blood loss, and so on. One more thing that is extremely useful is the first thing to get worse in sick patients is their respiratory rate. So the first thing that will increase, as you see, as we move from class 1 to class 4 shock, the patients will become tachypnic first, then their heart rates and their blood pressure may actually remain stable in class 1 shocks, and they might be slightly anxious. Urine output, so catheterization in polytrauma patients is quite important. Um, the reason is that it gives us an objective measure of their circulation or their perfusion, basically. Now, some of us might have seen these pelvic minders. So the most common one that I've seen in most trusts is this one. But if you can't find a pelvic minder, then you can actually use a couple of sheets to provide the same effect as well. This is basically a Kendrick splint for femoral injuries, and this is a tourniquet, which is shown many times in the actual ATLS as well. Um, and it's actually a military grade tourniquet that they use, especially in polytrauma patients in many centers. So intraosseous access. So basically the intraosseous access these days, the tibia itself is falling a little bit out of favor. They're going more towards um, getting IV intraosseous access in the proximal humerus. The reason for that is that they're suggesting that we're seeing many fractures with the insertion of these intraosseous devices into the tibia. But practically, if somebody is very sick, then you have to get access somewhere. If you're not one or another place, we have to get access, and one way or another we need to get that done. So next we move on to disability. So basic assessment of disability is basically checking their Glasgow Coma scale to check, especially in patients with head injuries, and checking for the pupillary reaction as well, if they're reactive to light or not. And blood glucose is also a part of disability. So the GCS is actually given in this slide. Many of us actually who are working will have used it, and we used it on a day-to-day basis. It's very useful to know it, and if we're working, we normally are able to remember all the points over here. So 13 to 15 denotes a minor injury, and 9 to 12 is a moderate brain injury, and anything below 8 or below is a severe injury. And exposure is, so in terms of exposure, we should be undressing the patients completely and cut off all their garments and check for any injuries to any areas of their body. And after we have done that, we should be covering them with blankets to prevent hypothermia as well. And we should be giving them warm IV fluids so that they don't become hypothermic. Now we move on to secondary survey now. And the first thing in secondary survey is to actually get a quick ample history. So ample history is basically a history of their allergies, medications, past medical history, their last meal, and the events around the time of the injury as well. So full history can be taken, but it should be done usually after a secondary survey is completed. And the mechanism of injury can usually give us quite a lot of clues about what injuries may be present. A full head to toe examination is really important, and we should be doing a log roll to check for spinal tenderness as well, unless there are contraindications for log roll. So one contraindication for a log roll is basically a pelvic injury. We should not be doing log roll on these patients unless we're completely sure, and we can do a log roll after a CT scan has been done in these patients, but usually the CTs would be helpful in checking for spinal injuries as well. Now, another point of secondary survey is basically we should be ordering further investigations. So getting investigations such as ultrasounds or CT scans it should be done at a secondary survey stage. And if a patient becomes unwell at any point when we are assessing them, or if we reach an impasse, we should go back to our primary survey and start from assessment of the airway again. And secondary survey should only be done once a primary survey has been completed, which basically means that all the problems with the primary survey have been identified and they're being addressed at that stage. You cannot begin a secondary survey without completing your primary survey, or basically management for the primary survey. And definitive management is another point. So it's basically comes at the stage of a tertiary survey, uh, what we call it a tertiary survey. So these are a few questions, and usually they're um, answered with senior support as well. And these include things like whether a patient needs to be transferred to another center. Now, at that stage, we need to think about how they're going to be transferred and what status they're in, and what they're going to require during this transfer as well. Whether they're going to need um, a doctor going with them, because if there's very unwell, they might get critically ill while they're being transferred, and for that reason, a doctor might need to be present over there. And if any services are present, so if we have all the services locally, or we are sitting in a tertiary referral center and we have IR, we have all the surgical specialties who are in under the same roof, then any interventions we're going to do, this should be prioritized based on ATLS principles or A to E principles. So any problems with the airway should be sorted out first. Any circulation problems. So let's say if somebody has a head injury um, and has a bleed in their head, but at the same time they also had a severe blunt trauma to their abdomen and they're now very unwell, and they're hemodynamically unstable um, and they're in hemorrhagic shock apparently, then these patients should go to the theater first for their abdominal injuries where they might be bleeding from any of the solid organs or any of the vessels, and that should be sorted out first, and their head injury should be dealt with after that. So all the interventions that they will need, they will also be prioritized based on ATLS principles. And another important thing is if somebody is coming in with open kind of injuries, then we need to give them antibiotic cover, tetanus prophylaxis, and we have to liaise with specialties as well to check what the investigations they might need. But this is all part of the definitive management or the uh, so-called tertiary service. Now, there are a few groups which we should focus on, such as elderly patients. So in elderly patients, they can sustain severe injuries, and I have seen it from experience that even from minor trauma, just such as just falling off from the bed, I've seen severe injuries in these patients, such as rib fractures leading to lacerations of their liver or their spleen. And another important thing is in non-accidental trauma, or if we have seen somebody come in with trauma after less, just like having a syncope or something, then we need to find out the medical cause which led to this injury as well, and this should be dealt with as soon as resuscitation has been completed. CT. So we have heard about NICE guidelines and Canadian CT head rules as well as NICE guidelines for CT cervical and cervical spine, as well as CTs for the head, which I have tried to summarize over here. It looks like quite a busy slide over here, but any patients who are, the gist of it is that the things we should be looking out for in patients with head injury include a GCS less than 13, or a GCS at initial presentation, or a GCS less than 15 2 hours after the injury, or if there's any suspected fractures, any seizures, or more than one episode of vomiting or neurological deficits, then we need to get a CT head in these patients urgently. and patients on blood thinners should be having CT scans within 8 hours as well, as per NICE guidelines currently. And CTs for the C spine. So any patient who's so the gist of it is basically any patient with low GCS or who needs intubation, or they're having they have a they're having other areas of their body CT scan, we should consider a CT of the cervical spine in these patients as well. So the conclusion is basically we need to go for a structured kind of approach according to ATLS. And one of the key elements which makes sure that a proper management plan is provided to a patient is effective communication and effective leadership. And we should be keeping a very low threshold for imaging according to current ATLS guidelines, especially in elderly people. And the third thing is that if we are going to manage them quickly after identifying their injuries, this is going to improve their outcomes. And specialist service referral should be sought after stabilization of a patient. And apart from that, we should be focusing on causes of the injury as well, especially in patients who have who might have other contributing factors which led to their injuries. So thank you very much for all your time right now. Now I'm going to take some questions, and if anyone has any questions or if anyone wants to ask anything, um, I am available over here. Any questions?
If anybody wants to ask any questions, they can unmute themselves and they can ask the questions directly, or they can type in the chat box.
Okay, so okay, so Osama has asked, what is the best way to study for an exam and what should we prioritize while preparing for examinations as well? So the best ways to study for an examination are basically, so these exams that we are having, the MRCS, these are very focused on our day-to-day work or our actual job. One thing is that the best way to study for an examination, I would just say you should find some partners or some people who are preparing for the same examination, and stick to a few things, because there's hundreds of resources that you will find for MRCS-A and MRCS-B, but stick to only a few things which have been tried and tested by some people you know already. um, I can help you out, or if you want to ask me privately at some time, I can let you know the things that I have used. Um, these were basically for MRCSA, as far as I remember. These were mostly question banks. EMRCS was the best one at that stage, but I have heard from some of the people who have been taking these. I took my exam something like 3-4 years ago. So since then, it has changed a little bit, and some people have said that there are a few other question banks which are um, which are better these days, or they have more information. But for MRCSB, there are past papers available. In terms of prioritizing things, I think the first priority should be to go for things which are generally asked or which are hot topics. So you will find many of these things, especially for part B, you will find some hot topics. So there are some past papers which are available online. I can provide those to you if you need. Um, they have some core topics, so we should know at least all of those things. And these will include basically things like ATLS, CRISP assessments, then our basic physical examinations. Apart from that, communication is another station that they're very um, that sometimes people find difficult, but usually if we are seeing enough patients ourselves, communication should not really be, those stations should not be really be too much of an issue. Now, for part A, it's very dependent on the specialties as well. So the exam is highly focused on general surgery, and I've seen orthopedics. That was the case when I was taking it. Um, Other specialties such as neurosurgery, you do see some questions on that, but not an awful lot. And vascular surgery, you will find a station, or you will find if quite a few questions on vascular surgery during the examination. But the main ones to focus on are general surgery and orthopedics. And if you know these two subjects, then you don't really need a very large amount of knowledge base for the other specialties, basically. Any other questions, guys?
I think that's all. Thank you so much for this amazing lecture. It was very simple, and I recently took ATLS and you explained really well. Everything was brilliant and to the point. So thank you so much for taking your time. And we have recorded this lecture and we'll send this lecture to everyone who wanted this lecture. There is around 100 people who are we're basically taking these lectures, and we have people from all over the world, basically Pakistan, India, UK, Ireland, Saudi Arabia. So thank you so much for today's
Thank you,
time.
Tala.
It was a very good lecture, and we really enjoyed it.
Thank you, Tala.
Thanks.
Have a good
Thank
day.
you very much. Thank you.
Have a good evening, everyone.
Yeah. So we will be back next Thursday with the new speaker, and thank you so much. Take care.